I'm Katie Brown and I'm a student physical therapist assistant from Jeff State. And today I'm going to talk to you about the physical therapy approach for children with cerebral palsy. Although scientists have not been able to define the exact cause of CP, it is believed to be a result of brain malformation that occurs directly before, during, or very shortly after delivery. It can be considered congenital or acquired. It occurs in as much to 2 to 2.5 children for every 1,000 live births. This can be caused by labor lasting longer than 18 hours, a trauma that occurs during birth, such as an injury from a forceps or other assistive device, and sometimes in premature infants with very low birth weights. Oftentimes it's seen in multiples, such as triplets and quadruplets and the like. It can also be caused by an in utero infection, maternal infection. Mortality rates for this disease are almost as complex as the disease itself. The complexity and severity of the impairments are the main contributors to mortality, and children that have severe mental retardation as a component are at the highest risk of early death. However, it is possible for most children to have a completely normal, fulfilling life. Clinically speaking, there are several manifestations that may be seen dependent on the severity and type of cerebral palsy. Chronic spasticity is an important issue to address early in therapy, as it can lead to contractures and may even require surgical intervention such as muscle lengthening if it becomes too severe. It can be classified by the type of the muscular involvement and then by what limbs are involved. Monoplegia, diplegia, hemiplegia, and quadriplegia are all subtypes of this type of spasticity. Dyskinesia and dystonia are seen in approximately 15% of CP patients. It's involuntary muscle contractions, which also often give children the appearance of being restless and unable to control their movements. Dystonia can be present, and it can make it difficult to sit, crawl, or walk. There are also some components of dystonia that can be seen that are called oral dystonia and affects the facial and tongue muscles, which make it difficult for the child to swallow and or speak. Ataxia usually presents difficulties in areas such as crawling, walking, and sitting as well. It also can affect the upper extremities, which becomes very important for children when they get to be school age and they're unable to hold a pencil or use their upper extremities in the classroom. Hypotonia can be seen in the early stages, but is not as commonly seen. It's a very small percentage of children present with hypotonia. It is not unusual to see patients that have a variety of these issues. There's no cut and dry presentation for cerebral palsy, and children may present with two types, as well as also components of motor disorders and mental disorders together. So therapy is very different for every child. The level of cerebral palsy is defined by the General Motor Functioning Classification Scale. The higher the number on the scale, the more severely the child is impaired. Although this is considered a non-progressive disease, signs do change as the child ages. As they grow, just as any child would grow, they would gain more motor skills. And so while they might be delayed in some areas and they have these issues such as hypotonia or ataxia, they still would progress physically. So as that, you're going to see changes in therapy as the child grows. So it's important to work with your PT in the plan of care so that you're giving the appropriate therapy for the child at that time, but at that child's pace. And with this scale, it is divided by age, and it goes all the way from infant to adult. There are multiple practice patterns that go along with this. It's 4A, primary prevention, risk reduction for skeletal demineralization. 4I, impaired joint mobility, motor function, muscle performance, range of motion associated with bony or soft tissue surgery. As we talked about before, sometimes there are muscle lengthening surgeries that are required. 5C, impaired motor function and sensory integrity associated with non-progressive orders of the central nervous system. This is a central nervous system disease, so you would want to address those sensory issues. There's impaired ventilation and respiration, gas exchange associated with vent pump dysfunction or failure. This can affect the respiratory muscles. Sometimes children with the most severe can't end up on ventilators, so you want to be able to address that. And primary prevention, risk reduction for integumentary disorders, and that's pattern 7A. So the interventions with children diagnosed with CP should begin as soon as possible. Even in early infancy, a program can be developed to ensure the child is fully able to reach their potential. Therapies at this stage would include working with the infant on rolling, sitting, and crawling. It's important to begin range of motion activities even before those are available. Just simple actions that we've learned in class, just the upper extremity motion, lower extremity, even trunk to facilitate that rolling. As the child grows, a plan of care would need to adapt to the child's needs. As each task is mastered, you begin to work on the next, such as crawling to walking. It's important to remember that these are children. Incorporating games is highly important because to keep the child engaged. You would want to do seated ball rolling activities to work on trunk flexion and upper extremity range of motion. You could do kicking the ball to work on standing and walking and facilitating that movement, that trunk swing. You could also do simple exercises, reaching even as small as tiny infants to place something in front of them that they want and they're going to reach. And you could work on upper extremity range of motion. Of course, you're dependent on the severity of the impairment would determine the child's potential to participate. The cognitive aspect is very highly important, making sure that your child is able to understand the directions. You might have to do pictures or songs or just get whatever it takes to get the child engaged. Parents are key. Parent and family education is a very important aspect of the PTA program and what we would want to design, because parents are often feeling overwhelmed by taking care of a special needs child. They often feel alone and overwhelmed, and they're not really sure how to participate in therapy. So it's important that you create a home exercise program that is all-inclusive, even including brothers and sisters or whoever is available, so that they are able to understand what's happening, help, and be engaged, and so that prevents isolation of the child that has special needs, that they are all-inclusive. And my why, my sweet Patton. Patton was born with a very mild case of CP, but he did present with some issues. He's my cousin, and he is precious, and he had difficulty walking. As you can see in the picture, he does have an ankle foot orthosis. He had difficulty walking and has spent a lot of time in therapy. But with the help of his therapist, he runs, he kicks, he plays ball with his brothers. He has very little signs of issues. Of course, we know that he has some struggles, and maybe he did for a time, but as of right now, he's starting kindergarten, he's functioning in the classroom just like any other child would, and he's just adorable. Alright, these are my references. This is great reading points. Wonderful topic to explore deeper into. I could talk about it all day. So I encourage you to look these up and continue reading, and thank you for listening to my presentation.